The Academy of Managed Care Pharmacy 2026 annual meeting covered a vast number of topics within the space, attracting a variety of healthcare practitioners ready to discuss and make changes to improve patient outcomes, increase accessibility, and inform policy decisions. My name is Sabrina McCrear, Assistant Editor at AJMC, and this is Beyond the Clinic. On this episode of Beyond the Clinic, I'm diving into my coverage at AMCP 2026 in Nashville, Tennessee, where I spoke with a host of key opinion leaders who sat on education sessions dedicated to addressing and resolving gaps in access to care, like Adam Colborn, for example, Vice President of Congressional Affairs at AMCP.
So, what are the biggest federal policy priorities coming out of AMCP 2026 that stakeholders should be paying attention to right now?
Well, I guess I can start with AMCP's priorities. There's a couple of bills that we've been working on for a few years now. The Medicaid VBPs for Patients Act, or MVP Act, the Access to Prescription Digital Therapeutics, or PDTs Act, and the Equitable Community Access to Pharmacy Services Act, or ECAPS. Those are sort of our advocacy priorities. The MVP Act is focused on increasing the use of value-based care in Medicaid, so expanding access for Medicaid beneficiaries to high-cost therapies like cell and gene therapies, or sort of in that specialty arena, which is a growing segment of the market, where value-based care is maybe a higher priority because of highly individualized outcomes. The next bill, the Access to Prescription Digital Therapeutics Act, is focused on creating Medicare and Medicaid benefit categories for PDTs. Because they are, and Medicare in particular, is a defined benefit program, if there isn't a statutory benefit category for something, Medicare just can't cover it as a matter of law. And sometimes they can get creative and fit new products or services into existing benefit categories. That's not always the case. With the case of PDTs, it's certainly not something they can do. And so this would create a new benefit category specific to this sort of new modality for treatment, and it will hopefully increase patient access to these therapies, which we think have a lot of potential to help reduce barriers to care, especially where there might be a provider shortage for mental health or substance use or whatever the treatment is. And then ECAPS, Equitable Community Access to Pharmacy Services. This would reimburse pharmacists under Medicare Part B for the testing and treatment of certain respiratory diseases, so flu, RSV, strep, COVID. And right now, for Medicare patients, they get the services, or excuse me, they get the products, so whatever the cost of a test or treatment, they get those reimbursed by Medicare, but with the other part of it is their time, and that doesn't get paid for. And so this bill would help do that, hopefully promote access to care for Medicare patients.
And what legislative or regulatory changes discussed here could most directly impact formulary decision making?
So there's one bill that's under consideration for Congress right now. It's the Alternatives to Pain Act. And that's an example of a coverage mandate, basically. It would require that Medicare Part D plans cover certain non-opioid pain management drugs on their lowest tier with no cost sharing, no utilization management. And so in that sense, that's a direct order from the government to a government program that this drug has to be covered. But the problem with it is that these drugs are very expensive. And so we've seen a lot of instability in the Part D market recently, with plans either reducing what they cover or withdrawing from markets entirely. And so there's, I think, a balance maybe that isn't being perfectly managed on what does access mean beyond simply ordering that a drug is covered? And so, I think some of the things that we're focused on, like the MVP Act or access to PDTs or ECAPs, are probably more aligned and do a better job of balancing access to specific services with access to health coverage as a whole.
The cost of therapies and drugs was a significant touchpoint at AMCP this year. Gene and cell therapies, like Colborn described, are substantial advancements in healthcare, especially when treating inherited disorders, hematologic malignancies, and progressive neuromuscular diseases with the potential for remission or even cure. But these therapies are also incredibly expensive, with some one-time treatments routinely priced above $3 million. That's why advocates say bills like the MVP Act are imperative to expanding life-changing therapies for Medicaid beneficiaries, as access remains disparate across race, socioeconomic status, geography, and insurance type. In one unfortunate example, studies assessing the utilization of CAR T-cell therapy found that patients treated in well-resourced academic centers with generous insurance, most often employer-sponsored, are more likely to receive this therapy that helps them fight cancer. And bills like the PAIN Act aim to address cost disparities in access to prescription drugs, which are an ongoing problem not just for opioids, but a wide variety of agents. In a conversation with Dr. Patty Tadai Allen, a clinical assistant professor at the University of Florida, she explained how amid the cost increase in specialty drugs, copay models like accumulators, maximizers, and alternate funding programs, although they aim to reduce healthcare spending overall, often end up increasing out-of-pocket costs for patients.
And for stakeholders who may not fully understand the nuances, right? How do accumulators, maximizers, and alternative funding programs differ in structure and intent?
Yeah, so I like to think about them in kind of two different levers. So when we're thinking about the copay maximizers and the accumulators, what they do is they reside within the existing benefit, and what they do is they're in essence just shifting some of the costs and when those patients are going to be exposed to those costs. Whereas when you're looking at an alternate funding program, you're actually removing that drug from the benefit. So that drug is no longer covered, is no longer on formulary. And with an alternate funding program, usually it requires a third party or an outside vendor to help administer that program.
And so while these programs do reduce plan liability, what does real-world evidence show about the impact on patient access, adherence, and out-of-pocket burden?
So, it's interesting because there have been some studies that have come out that have been, published in the literature that, the results can be kind of varied. What we're seeing with some of these accumulator and programs in particular is that patients may believe that they're having, they have met their deductible or they have a lower cost share, and then suddenly when that copay card runs out, perhaps mid-year, they suddenly have kind of a sticker shock. And so when there's that sticker shock, sometimes they may not be able to afford the medication that month, or you start seeing some reductions in adherence. On the other side, when we're thinking about the copay maximizers, while that the copay card amount is usually smoothed out over the year, there's less of that copay coverage kind of running out and having some of the sticker shock. But what some studies have shown is really that there might be these spillover effects, so that the patients may think that their deductible has been met because they've been having this kind of steady copay or very small copay or no copay at all for their specialty drug, but then they're not meeting that deductible that they had been meeting in the past. And so then they're surprised by other non-pharmacy or non-prescription medication cost shares like imaging or other types of medical services. And so you might start seeing that patients out-of-pocket exposure to some of these other services that they're receiving, and they're not used to that, and they're not aware of that. And then from an alternate funding, that's really mostly focused not so much on adherence or on discontinuation, but really on the data that is out there is really focused on kind of process, the time to therapy, how long it's taking for some of these patients to receive that medication, as well as some of the patient satisfaction associated with that.
As of 2025, nearly 40% of commercially insured patients were enrolled in a copay accumulator program, with a similar share enrolled in a copay maximizer program. Now, this percentage of employees is a significant increase from 2020, when only 27 and 24% were enrolled in these programs, respectively. And it's important to note that these cost shifting strategies are more prevalent among private insurance plans or employer sponsored plans. But it's still important to note that these strategies address a growing disparity in healthcare, the increase in prescription drugs, and healthcare deductibles. Now, healthcare plan deductibles have skyrocketed in 2026, especially for plans on the ACA marketplace, which rose anywhere between 17% and 40%, meaning individuals on bronze plans could have an average deductible of about $7,400 a year, and on silver plans, an average of $5,300 without cost sharing reductions. And for high deductible plans for 2026, individuals can expect an average of $1,700 and families $3,400. Additionally, patients are worried about the increasing cost of their medications. While about 60% of adults believe that medication and drugs developed in the past 2 decades have improved quality of life, more than 6 in 10 adults say they are worried about being able to afford these prescription drugs, whether for themselves or for their families. The education sessions weren't the only highlight at AMCP. The expo hall featured over 500 poster abstracts covering a wide variety of new, innovative research. One in particular also addressed patient out-of-pocket cost burdens for those on commercial insurance. The presenter and lead study author Ulrich Neumann, Director of Access and Policy Research at J&J Innovative Medicine, described how rising out-of-pocket costs have shown to significantly burden patients, especially those with multiple comorbidities.
We did this study because we heard a lot of feedback in patient groups that the affordability of prescription drugs, even for people who are on insurance coverage, is still a major problem. And then we've witnessed that over the last decade. There's a lot of changes in insurance design, high deductible health plans that have really reshaped how much patients have to pay out of pocket. We found that the total out-of-pocket cost over the study period of 10 years, more than doubled for all patients, and the steepest growth was in the last 5 to 6 years. And we also found that those with multiple comorbidities have been progressively higher exposure and higher burden. And so that raises a lot of questions of why people who are sicker actually are being taxed with more burden just because of their status, just because of their illness. One of the other things we did is we looked at how does the growth in out-of-pocket cost compare to the growth in wages, just to have an affordability benchmark. And we found that actually over the 10 years we looked at, in 8 of those 10 years, out-of-pocket costs have outpaced the wage growth. So that definitely raises the question of whether people's earning capacity has kept up with the growth of out-of-pocket costs.
These questions are just another reason why meetings like AMCP are so important. They bring together pharmacists within the managed care space to discuss how patient access can be improved, share breaking research, and inform policy reform. If you enjoyed this episode, don't forget to like and subscribe for more health policy and research insights. And for more AMCP conference coverage, visit AJMC.com in the caption or follow our social media pages below on Facebook, X, LinkedIn, and Instagram to stay up to date on more to come. Thanks for watching.